have with breast carcinoma, with one slide with carcinomatous metastasis in a lymph node, and then with the benign mesenchymal tumors. And tomorrow, maybe at the same time, you will continue with Dr. Vlachova with the rest of the mesenchymal tumors, the malignant mesenchymal tumors, and the tumors of the nervous system and hematopoietic system. So let's start with the breast carcinoma. First, before I start showing you the slide, I just want to say a couple words about breast carcinoma as a disease, because it's really the most common neoplastic disease in women. And you will definitely see such patients in your practice. So it's good to know what will be the risk factors for the breast carcinoma. First, this will be the early menarche and the late menopause. And this is because in this way, there is a wider time frame for the estrogens to work on the breast tissue. Another risk factor is the late first childbirth. And saying late, I mean after 30. And this is because after the birth and during the lactation, the breast parenchyma undergoes terminal differentiation, which is protective against carcinoma. And the earlier that happens, the better. So giving your first childbirth before 30 and breastfeeding is protective. Increased risk is for the obese women, because maybe you know in the peripheral fat there is conversion of the estrogens. So the more peripheral fat, the more estrogens again to work on that breast tissue. So these are the major risk factors, and you should always... Somebody said something maybe? And you always should have in your mind that about 10% of the breast carcinomas will be inherited. There will be a strong genetic background. So just have in mind that if you have young patients before 40 with the breast carcinoma, this is really suspicious for having such genetic background. And the most common genes that are associated with breast carcinoma, this is BRCA1 and 2. So if you have a young patient with breast carcinoma, send it to the genetic department for counseling and for blood tests for those mutation in those genes, because those patients will be at risk also for other cancers like ovarian carcinoma and colorectal carcinoma. So they should be closely followed, and their relatives too. Okay. So at first, we start with the first slide, which is going to be invasive lobular carcinoma of the breast. But first, we should recognize that we're dealing with the breast tissue. So here is the normal structure of the organ. How do we recognize that this is a breast? Here in the center of the field, we see the main structural unit of the breast. This is the terminal duct lobular unit. You can see the terminal duct in the middle that is filled with pink proteinaceous material. This is the terminal duct. And all those small acini that surround the terminal duct, they're making the lobule. So this is the main structural unit. Further down at the bottom, you see another duct, and all that is surrounded by connective and fat tissue. This is the normal appearance of the breast. So where actually does the breast carcinoma start? Here, the cells that are lining the ducts and those acini are myoepithelial and luminal epithelial cells. And between them, you have the so-called stem cells or progenitor cells that actually give, when they accumulate enough mutation, they give rise to the neoplastic proliferation. So at first, we suspect for those neoplastic cells to accumulate here within the lumen of the ducts and the acini. And at first, they're contained within that basement membrane. They don't breach the basement membrane. And we call that carcinoma in situ. Once they start to invade into the surrounding fibrous and fat tissue, we call that invasive breast carcinoma. Okay, we can stop here at that field. Here you see those invasive tumor cells that surround actually the normal structures of the breast, like lobules and ducts. We can use even the higher magnification. So here you can see those ductal structures with the central lumen, which are parts of the normal histology of the organ, and they are surrounded by the tumor cells of the lobular carcinoma. And before we continue to explain about the lobular carcinoma, I just want to say that traditionally, in pathology, the two main types of breast carcinoma will be the ductal and the lobular carcinoma. They comprise more than 90% of all carcinomas of the breast. And that division actually implies not only morphological, but also clinical differences between the two diseases. And they also have a different genetic background. So what should you know about the lobular carcinoma that we are looking at right now? Here the cells are discohesive, so they invade as single cells into the breast parenchyma without making any structures like ductal structures. They just freely invade. That model of invasion is called an Indian file invasion. And it's typical for the lobular carcinoma. And you can see here how they surround the normal structures of the breast. What is the genetic background of the lobular carcinoma? Most of them usually have lost their ecadherin, which is actually responsible for the cell contacts. So if they lost their ecadherin, we cannot expect from these tumor cells to make any contacts, to make any structures like ducts, for example. That's why they seem more rounded, more monomorphous population of cells that invades the breast tissue discohesively without making any structures. Another important thing for the lobular carcinoma of the breast is that it doesn't induce much fibrostroma. That's why it's really hard to palpate the tumor on the physical examination, and it's really hard to detect it on the imaging studies. And that usually is the reason why they're detected late in the course of the disease. And here again, you can see one ductal structure in the center of the field, a normal ductal structure of the breast, surrounded by all those discohesively infiltrating cells of the lobular carcinoma. And yet another important thing about the lobular carcinoma that differentiates it from the ductal is that the lobular carcinoma has a tendency to give a specific metastasis. Like we expect it to give metastasis into the ovaries, or also into the organs of the gastrointestinal tract, for example, in the wall of the stomach. They usually give metastasis in the serosal surfaces, like peritoneum, the meninges. This is something typical for the lobular carcinoma that differentiates it from the invasive ductal carcinoma. So those are the major characteristics of the invasive lobular carcinoma of the breast. Now I'll change the slide to the invasive ductal carcinoma so you can see the difference between both of them. Let's first look at this field. Okay, what is the difference that we appreciate here on that field? In the invasive ductal carcinoma, the tumor cells make cohesive structures like ductal structures with different size, different shape. In some of them, we can see a lumen, like here in the middle, we have couple ducts with the lumen. Because they retain their ecadherins, so they can make such cohesive structures. Another thing, the invasive ductal carcinoma induces production of really hard fibrostroma. This is called a desmoplastic reaction. So all that pink tissue that surrounds the dark purple invasive ductal structures is the stroma, the hard stroma of the invasive ductal carcinoma. That stroma actually helps to identify early in the course that tumor, because having that stroma, the tumor feels hard on palpation. So it's easily detectable on physical examination and also on the imaging studies. So we tend to diagnose the invasive ductal carcinomas earlier than the lobular ones. And just to convince you that this is an invasive carcinoma, we can find a field with invasion in the fat tissue of the breast, like here. You can see the fat tissue on the right side of the field and all those neoplastic ducts invading that fat tissue in the left side of the field. And having said about the in situ carcinoma, and that breast carcinoma usually starts from a neoplastic proliferation in the ducts. Here we can see an associated in situ carcinoma component right here in the middle of the field. You can see one ductal structure filled with tumor cells. This is called in situ breast carcinoma. And there is another duct filled with in situ breast carcinoma here. Again, right in the middle of your field now. So this is how that tumor starts in the ducts and in the lobules as in situ carcinoma, and then starts to invade widely the surrounding breast parenchyma. Again, we have two more ducts with in situ carcinoma here in the center of the field. They're really well delineated, so you can easily distinguish them from the surrounding tissues. And this is the periphery of the tumor invasion, where the tumor goes right into the fat tissue of the breast. And here we see a couple tumor emboli into the lymphatic vessels. We can have a higher magnification. You see a tumorous nest hanging freely within the blood vessels. Here we see two of them. There is one more. So this is what we call lymphovascular invasion. It's really a negative prognostic factor for a patient with invasive breast carcinoma. So for both of those tumors, the invasive lobular and ductal carcinoma, they both have metastatic potential either to the lymph nodes or to give hematogenous metastasis. So about the lymph nodes, what are regional lymph nodes for the breast carcinoma? Where should we look for the metastasis first?
In the axilla?
Yes, in the axillary lymph nodes, which are usually the first to receive the metastasis. Also, for the tumors that are located in the inner quadrants, the medial quadrants of the breast, we may see the metastasis in the parasternal lymph nodes or the lymph nodes around the internal mammary artery. Having metastasis in the supraclavicular or cervical lymph nodes from breast carcinoma means advanced disease. Those are considered distant metastasis. What about the hematogenous metastasis? The usual organs that are affected by hematogenous metastasis. This is usually lungs, liver, brain can also be affected, and bones. Okay, and something else that is really important for the breast carcinoma are some receptors that we actually test and that have really a great impact on the therapy followed the surgical resection. What are those receptors that we usually test in all invasive breast carcinomas? Those are estrogen, progesterone, and HER2. HER2 is a receptor from the EGFR family. So we test those three in all patients with invasive breast carcinoma. And yet another thing that we should mention is about the degree of differentiation of the invasive ductal carcinoma. They are usually divided into well, moderate, and poorly differentiated. And what are the criteria that we use to assess the differentiation of the invasive ductal carcinoma? We use three criteria. The first one is the percent of the tumor mass that makes ducts. The more ducts, the better differentiated is the tumors. If the ductal structures are less and the solid tumor masses prevail, that speaks towards a poorly differentiated carcinoma. So the percentage of the tubule formation is your first criteria for the degree of differentiation. Your next criteria is the cellular pleomorphism. And the third one is the mitotic rate. So we use those three criteria to assess if the tumor is well, moderately, or poorly differentiated. Because the degree of differentiation, together with the size of the tumor and the nodal status, the status of the lymph nodes, they have really tremendous prognostic influence about that patient. Okay. So those were your two slides from the breast carcinoma. Invasive lobular carcinoma that we've seen at first, and this one, which is the invasive ductal carcinoma. In your slide, even if you don't find a normal breast tissue right away and you cannot recognize your organ, don't be worried about that. Like at the beginning, it will be enough just to say, okay, I see here like neoplastic ducts. I know they are neoplastic because they are different size, different shape, because they invade here in the fat tissue. So I guess this will be adenocarcinoma, but I don't see the organ, so I cannot say what is the primary. This will be totally enough. Then your assistant will give you like a hint questions and you'll get to the truth. So don't worry if you don't recognize the organ at first. It's enough that you recognize the process that is malignant, that is adenocarcinoma, that is invasive. So you will be given hints if you don't see a normal breast structures in your slide. Mm-hmm. Okay, I'm sorry. Professor Ivanova came in to ask me something, so I turned off the microphone for a while. So we move to the other slide, which is called metastasis, carcinomatosa, lymph node, or these are metastatic lymph nodes. So again, we start with the more preserved part of the slide. This is the structure of a lymph node. How do we know it's a lymph node? Because we see a lot of lymphocytes, all those dark purple dots. This is lymphatic tissue. And we see the capsule surrounding that lymph node. That pink band that runs and surrounds the lymphatic tissue is the capsule. And here we see some fat vacuoles. This is called fatty metaplasia in some of the lymph nodes, and it's totally normal. Don't worry about it. And as we move further down, we see a lot of ductal structures, neoplastic ductal structures in that lymph node, which is not normal to see such epithelial structures within the lymph node. So we are pretty confident that we are dealing with metastasis of the lymph node. If we have only that lymph node and we don't know anything about the primary tumor, we are not able to say what is it. We can say, okay, it's adenocarcinoma because it's a gland-making tumor, but this is so much. That could be a lung carcinoma, that could be a breast carcinoma, stomach carcinoma, and so on. So we should have some more clinical information about the primary tumor, or if we don't, we should do some immunohistochemistry over that slide to see what is the histogenesis, what is the origin of that tumor. If this is a breast carcinoma, it's really important to say if the metastasis is contained within the lymph node or if it invades the capsule of the lymph node and the surrounding fat tissue. Why is that? Because if it invades the capsule of the lymph node, that means the woman has a higher risk for recurrence of the tumor, and she needs an additional radiotherapy to all other therapy assigned already. So it's really important to have, if you have a patient with breast carcinoma, to have in your report how many lymph nodes are metastatic, and if that metastasis is contained only into the lymph node or it invades the capsule of the lymph node. Usually all the metastases, they start from the so-called marginal or peripheral sinus. You see here the capsule of the lymph node, and you see that empty space that is running between the capsule and the parenchyma of the lymph node. This is the so-called marginal or peripheral sinus, and usually this is the place where all the metastasis starts, because this is the place where the afferent, the incoming lymphatics are draining. So we always have a closer look to that space to check for initial metastasis. Here it's easy because we see that the lymph node is widely metastatic, widely replaced with metastasis, but when we don't see that picture, we always check this space here under the capsule, the so-called marginal or peripheral sinus. Okay, this was your slide about the metastatic lymph nodes. And actually, with this slide, we end the malignant epithelial tumors. Now we'll turn to the benign mesenchymal tumors. My experience shows that they're like more easy to you than the epithelial tumors. So I guess it will be better with them. So just 2 or 3 sentences about the benign mesenchymal tumors. This is a group of tumors that are common to all age. For example, the malignant epithelial tumors are more common for the adults, but this one, the benign mesenchymal tumors, could be seen in any age, in children, in adults. In the epithelial tumors, we were talking about nests or glands of tumor parenchyma surrounded by stroma, and the difference is well visible. But here, the tumor cells, the parenchyma and the stroma are really jumbled, mixed up, and that difference it's not so visible. That's why their cut surface grossly is more homogeneous of the mesenchymal tumors. So now you're looking at the first mesenchymal tumor that we're going to look. This is dermatofibroma. Actually, what is a fibroma? This is a benign mesenchymal tumor originating from what type of tissue? Fibrous, fibrous connective tissue. Where can we see that fibroma? Apparently, in the skin, in the dermis of the skin, like the case here. Where else we can see fibroma? Any other places? We can see it also in the oral cavity. It is usually called like traumatic or irritative fibroma in the oral cavity because it's due to a chronic trauma. For example, poorly fixed dentures is one of the cases here. We can see a fibroma in the ovary. And also we can see a fibroma of the tendon sheaths. Those are really the most common places where you can see a fibroma. So here on the right side of the field, you see the squamous epithelium with thick keratin layer at the top. And on the left side of the field, you see the dermis. And if we take a closer look to the dermis, maybe we can stop here. We see many cells jumbled up with strips of pink collagen because, as we said here, the tumor cells are in close contact with the stroma. So the tumor cells and the stroma are making bundles crossing in different directions. So all the cells with the purple nuclei that you see
Ο
here.
Μουρχουτάς τον παίρνει.
Can you say that in English? So all the cells with the dark purple nuclei, they represent fibroblasts and fibrocytes. This is the parenchyma of the tumor. And all the pinkish strands that you see between the cells is the collagen that is produced by the fibroblasts. And all that is really mixed up. This is the classic picture of fibroma. And we have one special stain for that collagen. So if you're asked what special stain do we use to prove that collagen here, those pink strands that they are collagen, that stain is Van Gieson. If we use that special stain, all that collagen should stain red, and all the other cells should stain yellow. Okay, this is how that special stain Van Gieson looks. So all the collagen, you see all the collagen strands stained in red, and everything that surrounds them, everything else is in yellow. This is your special stain, Van Gieson, and we use it for collagen. And because the fibroma is really rich in collagen tumor, we see a lot of those red collagen bundles here within the tumor. Okay, so we move to the next benign mesenchymal tumor. So do you recognize what type of tissue is that?
Maybe from muscle?
Yes, smooth muscle. We see a thick smooth muscle here, and we see those thick-walled blood vessels that I was explaining to you in one of the previous slides. And I told you that when you have such a thick, smooth muscle and those thick-walled blood vessels, you're usually dealing with myometrium. So this is the case here. We're looking at the myometrium. And as we keep moving further, we see here to a well-delineated tumor formation composed of smooth muscle bundles again, like the one here. So we're dealing with a benign mesenchymal tumor composed of smooth muscle, and this is called leiomyoma. So this is your slide, leiomyoma. Usually the leiomyoma doesn't have a capsule, but it is well delineated from the surrounding tissue. And you can see that line here in the center of the field. On the left part of the field is the leiomyoma. the tumor, and on the right part is the smooth muscle of the myometrium. So this is the most common place of the leiomyoma to be seen in the myometrium. Other places where you can see leiomyoma, these are the dermis. In the dermis, they usually arise from the small muscles called arrector pili muscles, and this is the so-called pilar leiomyoma. Also, you can see leiomyoma in the walls of the blood vessels because they also have smooth muscles, or in the walls of the hollow abdominal organs, like stomach, small, large intestine, even in the wall of the esophagus. So those are the common places for leiomyoma. Smooth muscle tumors that, again, it's making all those intersecting bundles from smooth muscle cells. Again, it doesn't have a capsule, but is well delineated. The smooth muscle cells, unlike the fibroblasts, they don't have the potential to produce collagen. So if we make that special stain Van Gison here, we won't find any red areas corresponding to collagen. So we can look to our special stain Van Gison for the leiomyoma. So you can see here that you don't have those red appearing bundles of collagen like in your slide dermatofibroma. It's because leiomyoma doesn't produce collagen. Everything is yellow. If we had collagen, we should see those red bundles. So just have in mind that you have two special stains, Van Gison for the dermatofibroma and leiomyoma uteri. And if you see something yellow or yellow and red, this is your special stain called Van Gison. Okay, and the next benign mesenchymal tumor is which one? What type of tissue are we looking at right now?
Brain.
Why brain?
I'm
We
not sure
don't.
why.
We don't see neurons.
The lungs?
No.
It's adipose tissue.
What type of tissue?
Adipose.
Adipose tissue. I agree about the adipose tissue because we see all those empty spaces that actually represent the lipid vacuoles within the fatty cells. If it's a lung, we should see bronchi, bronchioles, but we don't see that here. And the walls of the alveoli are thicker than those septa that we see here. So we're looking at the fat tissue, and that fat tissue is surrounded, it's contained within a fibrous capsule. You can see that pink line is the fibrous capsule. So if we have a tumor mass surrounded by a fibrous capsule, we go with the benign tumor arising from fat tissue, and this is lipoma. And all that fat in the cells has been extracted during the preparation of the slide. because during the preparation the slides goes through all the alcohols and they just extract, dissolve the fat tissue, and there is nothing to stain with the hematoxylin and eosin within those cells. So it's a really common benign tumor from fat tissue, lipoma. We can see lipoma everywhere in our body in the subcutaneous fat tissue. So everywhere you look, the picture is the same. And that capsule that delineates the tumor sends a fibrous septa that dissects the tumor. Here you can see two fibrous septa running through the slide. They are sent into the tumor from the capsule and they are dividing the tumor. There is another one. Okay, so this is the view of the lipoma, a benign mesenchymal tumor from fat tissue. Okay, and your next slide. So, to what type of tissue reminds you that picture? I can use the higher magnification.
Cartilage?
Yes, it looks like hyaline cartilage. So we are sure with our diagnosis, chondroma. This is chondroma, a benign tumor that resembles and arises from hyaline cartilage. So here you can see the groups of chondrocytes. Those are the cells with the dark purple nuclei, and they're surrounded by that bluish stroma that you see. Those are actually the acid mucopolysaccharides that comprise the stroma. So what is the most common place where you can see that tumor?
Joints.
What joints? The smaller bones. The short, small bones.
Interphalangeal.
Yes,
Interphalangeal.
interphalangeal. So those are the small bones of the hands and the feet. This is the typical place of that tumor. It can usually grow either towards the cavity of the bone. In this way, it's called enchondroma, or it can grow outwards towards the periosteum, and in this case, it's called echondroma. And what is the most common clinical presentation of that tumor? This is the pain and the pathologic fracture of those bones. And because that tumor is avascular, you can see those areas with the cystic degenerations here. And also here in the center of the field. Otherwise, it's not hard to recognize it because, as you said, it looks like a hyaline cartilage. And when you see that picture, you're sure you're dealing with chondroma. You have no other slides like it. Okay, and the last mesenchymal tumor for today. You can make the organ diagnosis here.
Liver?
It's a liver, the typical structure of liver with the portal spaces. There is some steatosis, those empty vacuoles that you see. And then as we continue to look, we see that vascularized tumor formation that is well delineated from the surrounding liver parenchyma. So how do we call a benign mesenchymal tumor originating from blood vessels or making such vascular structures?
Hemangioma?
Yes, this is hemangioma. So your slide is called hemangioma cavernosum hepatis. This is the most common benign tumor of the liver. So you have all those vascular spaces surrounded by fibrotic tissue. They're not true blood vessels because they don't have the normal structure of a blood vessel, but they're lined with endothelial cells. Here you see some blood in all of them. You may see thrombi in some of those spaces. Most of those tumors are asymptomatic and they can really undergo unnoticed. So they're usually found out during some checkup for the patient for something else. Or we usually see them at autopsy, like an incidental finding. They can be symptomatic if they are large and if they're located under the capsule. So in this way, there is always increased risk for rupture of that tumor and massive spillage of blood within the abdominal cavity. And how do we call that situation? When you have blood in the peritoneal cavity. Hemoperitoneum. Hemoperitoneum or hemascus is another word for it. Does the tumor have any malignant potential? No, it doesn't. And how do you call the malignant counterpart of that tumor, of the hemangioma? It's angiosarcoma. Angiosarcoma is the malignant counterpart, but it doesn't arise on the ground of hemangioma. It usually arises by itself de novo if we see it in the liver. So I think this slide is one of the easiest because you recognize the liver, you see that good vascularized tumor mass that is well delineated, and your diagnosis is hemangioma cavernosum hepatis. Okay, so we got to the last slide for today. So tomorrow you will be with Dr. Vlahova. She'll continue with malignant mesenchymal tumors. And I don't know if you will have any other time for something else. So if you have any questions, you can ask.
Professor, what about the two slides for lungs and prostate from the previous topic?
You don't have them for the exam.
Okay, thank you.
Only those that we've been looking at.
Thank you.
You're welcome. Okay, anything else?